this late time, but as Ahmed said, actually, it's a very important subject. Actually, we sometimes don't give it enough attention, if you like, but I think it's a very important topic regarding these patients. And the reason I'm saying that is basically of how common it is actually we find it in our patients. So what I'm going to talk about today is going to talk about the risks that these patients actually um, we have in these patients with diabetes, the overall aim of the management of them, the golden rules, so we can speak the same language. We have sort of sets the scene to the intra and post-operative management. And then we'll talk about the stage of operative management, the aim of each stage, and then we'll pick one or two points without going into the details really, because the evidence on these are quite long really, and I think that will be outside the scope of this lecture. And I'd start with what I'm going to talk about today is a straightforward diabetic patients who is not having a diabetic pump or something like that. That will sort of these sort of patients we usually refer them to the diabetic team to consider how are we going to manage it with the pump. But anyway, let's start. Of course, it's fairly common, as you all know. It affects about 10 to 15% of our surgical population coming surgery. They actually have a very high perioperative glucose. These patients have very high perioperative risks, really. Whether they come for emergencies or elective settings, they usually constitute sort of a very high risk surgical patients. The adverse outcome in these patients mainly due to few factors, really. Anyway, how risky it is there's a 50% increase in the mortality in these patients, as evidence shows. 2-3 folds increase in postoperative respiratory infections, twofold increase in the surgical site infection. Again, the same sort of rate of increase in the air tract infection and increase in the acute kidney injury. So they are very high risk also. We wouldn't forget the acute coronary syndrome that these patients actually, and again, all the risks on these patients are at least double the normal in a normal population, as we all know. The reasons for this poor outcome is multifactorial, to be fair. Part of it is failure to identify the patients with diabetes or hyperglycemia. Okay, that's very rare nowadays because we have we monitor these patients quite thoroughly, but it happens. Comorbidities with micro and macrovascular disease, as we all know, they have a complex pharmacy. There is still actually, even in with us, even in Western countries, insulin prescribing errors still happens really, and that constitutes sort of at least one minor factor um, in the reasons why they have the complications. Of course, they have associated perioperative infection rate higher than normal, and inadequate or lack of institution guidelines have served them. It's again rare nowadays, but some institutions still have not doesn't have clear guidelines of how to deal with the patients at different stages of their management. The overall of perioperative management, generally speaking, before we start, are threefolds, and these are linked to each other. Aim one is obviously thorough perioperative assessment and optimization, and the optimization nowadays defined as hemoglobin A1C of less than 69 millimole per mole. And again, I'm sorry because I'm giving this units because that's what we're using here, I'm afraid. Also, we have to decide if the patient can be managed on its own medications or it has to be put on a variable rate insulin infusion. Overall, also, accurate and well-informed communication between healthcare workers and between healthcare workers and patients is very important, is key in a good management of these patients. So we have to pay very much attention to that. Golden rules so we can speak the same language. To start with, dealing with insulin, I mean, imagining that these patients is a type 1, type 2 diabetic actually. The variable rate insulin infusion is now used rather than the sliding scale, or old people like me used to call it Alberti's regime, a GIK regime, where there's glucose, insulin, and potassium infusions. The reason for that is quite often actually we use it independently. We don't use it with each other. So that's one thing. The second thing is short starvation is actually recommended if we can, and if the patient have a short starvation, i.e. missing only one meal, will tend to modify its own medication. If it is a prolonged starvation, he will miss one meal or more. More than one meal, they be managed by variable rate infusions. We'll talk a little bit later on about the fluid recommended. And obviously, it has to be a safe prescribing of insulin. Everybody has to be trained how to use it, how to manipulate the infusion, and so on and so forth. When we come to the monitoring, capillary blood glucose has to be done hourly, so long as the patient is in theater. Guidelines for acceptable capillary blood glucose levels is published, and as we said, actually, we'll talk about it in a minute, but it is usually 6 to 10 millimole per liter. Training is mandatory for all the stuff of how to use this or how to monitor these patients. The WHO check bundle has to be implemented really, because due to this bundle, the risk of this patient, or the risk of errors, I should say, has improved quite a lot. Doing the WHO bundles at the beginning and at the end of the procedure, and as you're taking the patient from the reception area to theater, is very, very important. And it's definitely reduced the type of errors we get. To start with, before we talk about the management, what factors favors the modification of the current medication, in the sense of when would you say that I can basically modify the patient medication rather than putting them on insulin infusion? To start with, the patient has to be well controlled as defined by the hemoglobin HA1C. The patient has to be only missing one meal. Be done early in the afternoon, early in the morning, and also the patient himself will be able to manage his diabetic control, in the sense of hasn't got dementia or anything physical that will prohibit him from managing his own regime. Stages of preoperative assessment, usually different countries use different settings, but we can talk generally speaking about sort of primary care as it happens here. GPs, for example, as it happens here, they can refer patients for surgery. The patient can be referred from the outpatient surgical clinic. That's the second step. Preoperative assessment at the third step. Theater, the last, and then postoperative management, including discharge. That's the last step, and has to be aims for each and every one of those. That has to be and has to be guidelines for it, really. So let's talk about the aims of the individual stages. So to start with, from the stage of referral from the primary care and the one from outpatient surgical units, are more or less the same, really, to be honest. And it encompasses obviously checking that the diabetes is well controlled, all the comorbidities has been considered and put into the equation to basically give other decisions. Will it be the whole day, part of the day, morning, afternoon? And it should be optimally managed as well if the patient has ischemic heart disease. So all this has to be before the patient appears to theater. And this is the obviously the duty of the referring consultant, whether it is a GP or a surgeon. Has to check that the glycemic control is fine in the last 6 months. If not, and it's selective surgery, and it's not very something like cancer, for example, that has to be, for example, in the UK, we have to do this in a couple of weeks. Surgery has to be done, or decision has to be done within 2 weeks. In this case, if it is not that urgent, the patient has to be referred to a diabetologist, and of course, the clinic or the GP has to arrange for preoperative assessment. Come to the next stage is the preoperative assessment itself, and the aim of this stage is obviously make sure that the 6 months is definitely 69. There is no loose ends here. The patient should have a diabetic management plan. So in the preoperative assessment, depending on the surgery the patient will have, They will take the decision whether it is morning, afternoon. Patient should be first on the list. The admission dates, what they give a patient instructions to what they do with their medications. They do routine investigations. They take other decisions about other medications that these patients have. For example, if the patient is having warfarin and having something, a long procedure that sort of will necessitates bridging warfarin with something else, they organize that. Patient have a renal replacement therapy, they should actually organize that, these sort of things. And also identify the high risk patients. So if these patients are high risk, they should be admitted to critical care afterwards. On the day of surgery, the aim is to ensure that the pre-op plan that's been planned in the preoperative assessment setting is well executed regarding the timing, the location, pre and post, the medications of the patient, and so on and so forth. They have to see if the urgency of the procedure matching this plan or not, and the patient have proper instructions and they follow the instructions. Obviously, minimize the metabolic consequences of starvation, i.e., and give him enough substrates to avoid lipolysis, gluconeogenesis, ketogenesis, all these sorts of things. And above all, these patients should have monitoring of their capillary blood sugar regularly, hourly during the procedure. And then we'll talk about the post-op briefly and how these patients will be returned back to the normal regime afterwards. Of course, depends on the setting. So let's talk about the day of surgery. On the day of surgery, the patients will follow one of the following patterns, really. Patient should be first on the list. There is no doubt about it, whether it is a major, minor, morning, and afternoon. Okay, and we'll consider the urgency. And we have one of three situations here. Patients who's not well controlled, and that shouldn't actually come. These patients shouldn't come to this stage anyway. But if it happens and it's an elective patient, not well controlled, this patient easy will be postponed. There's no doubt that any patients who have an HbA1c above 69 should be done on elective basis for a hernia or any sort of minor bowel surgery, stuff like that. The other possibility is a patient who have elective well controlled. That depends very much, or having an emergency. If it is an elective and well controlled, the patient will be type 1 and 2, and obviously first on the list, whether they are in the morning or the afternoon. In emerging type situations, you have one of three scenarios. You have either a patient in diabetic ketoacidosis, and if the patient have diabetic ketoacidosis, this patient should be managed by a multidisciplinary team, in the sense of, if you're taking a patient who have diabetic ketoacidosis to theater, the decision to take him to theater will have to be discussed by the consultant anesthetist, consultant surgeon, preferably a diabetologist if it is a daytime hours, because obviously these patients mortality rate will be sky high if you operate on them while they are in DKA. They need resuscitation, and that's why you need the multidisciplinary team decision. If the patient is not in the ketoacidosis, he will be straight into variable rate infusion. The only situation in emergency setting that you be able to modify a normal medications if it is urgent, not emergency, in the sense of a patient who have fracture neck of femur that can be done next morning, for example. In this case, you can modify the medications and treat him like an elective patient. That said, I have to say that sort of before the operation, the elective patients should have this target capillary blood sugar. I think the 6 to 10, I think it's 110 milligram per liter rather than 10 millimoles per liter really. So, but that's the units we're using here. And also, this is a definition of the DKA. If ketones more than 2, capillary blood sugar more than 11, it could be higher than that, usually much higher than that actually. Bicarb less than 15 and pH less than 7.3. So these are what we should be doing on the day of surgery or different scenarios. Management of the existing therapy. Okay, and we're talking now about the elective patients because we already talked about the emergency patients. And these patients are either type 1 or type 2, and they either having insulin or oral hypoglycemic drugs. So for insulin, these are the different hypoglycemic drugs these patients might name. It might be long-acting, biphasic, intermediately acting, short-acting or intermediately acting taken twice daily, or short-acting taken 3 to 5 times a day. And we have to usually in our institution they have a pamphlet with them describing exactly how to deal with their diabetic drugs the day before. And this is what we usually do. I'm not going to go into the great details, but I will give you the gesture, a big quick gesture of what we actually do in our unit. So the patient, as you can see on this screen, could be in long acting, biphasic, intermediate acting, or short acting. So if you're taking long acting, and the scenario is if they have what they do the day before, what they do if they are sort of done on AM, PM, and if they are on variable rate infusions in the sense of if they are having a long surgery, for example. So in the day before, whether they are in the morning or afternoon, they drop their daily dose. If they are long acting, they drop the daily dose to 80%. On the day, if they are they check the blood. If they are done in the morning, they check the blood sugar in the morning, and then they have the 80% of their normal dose as long acting, and then carry on with the surgery. The same happens in the afternoon, so there is no difference here. If they are on variable rate infusion, we still give them their long acting, and the diabetologists will be very upset if they don't do that, even if they are not eating. Actually, still give them the long acting. If they're biphasic, they don't need anything the day before. On the day, they take only half the morning dose, okay? And then we'll check their blood sugar and carry on. Again, if they have short and intermediately acting, they do the same. They have half the morning dose in the same day, but the day before they do nothing. The same goes for the short-acting drugs. They basically they do no change in the dosing the day before, and then if they check the blood sugar in the morning and basically omit the morning dose in the morning, or omit the morning and the lunchtime dose if they be done in the afternoon. So basically that's what they do with their insulin requirements on the day of surgery. If they are taking oral hypoglycemic drugs, they again it will fall into one of three categories. There are certain drugs that we omit because the risk of hypoglycemia. There are certain drugs that we omit because of the risk of ketoacidosis, and this is just only one group of drugs. And there's some drugs that you continue anyway. So the meglitinides, like the natiglid and natiglinides and that one sulfonylureas, we basically omit them because of the risk of the hypoglycemia. Only the SGLT2 inhibitors have been omitted because of the risk of acidosis. The metformin used to be in this group, but now actually moved on to the drugs that will be continued on the day of surgery. And again, that's basically more or less what we do with these drugs. Just I'll give you an example. We already mentioned what we do with these drugs. On the day before, they do nothing. Okay. On the same day, you omit the sulfonylurea meglitinides, and if they're taking SGL2 inhibitors, they take the half dose. Okay. And basically if all the others they don't do the day before, the only one that have been taken on the same day are DPPs, the diabetic inhibitors. Okay, so that's basically roughly what we do with the patients will be given this information on the day. The pre-assessment nurse asks them which drugs they take, and they give them the pamphlet with what they need to do for those drugs. Depends on if they come morning, afternoon, or the day before. Most of the patients get admitted on the day of surgery, even if it is a major surgery, because they have pre-operative assessment, so they don't actually need to come the day before. Intraoperative capillary blood sugar management. I'm only mentioning here how we are going to deal with fluctuations in the blood sugar, to be fair, rather than anything, because it happens, okay, especially with the long procedures. For emergency procedures with the DKA, obviously, the emergency diabetic team, MDT, has to be consulted before you start. And if you have to start them, the regime will be managed by the team rather than by you. If the capillary blood sugar is high in the type 2 diabetes, we usually manage with 6 units of insulin. Is a type 2 diabetes, we usually give them a bolus dose of 0.1 units per kg with a maximum of 6 units. In this case, you can actually repeat the 6 units in about an hour time, but not less than that. And then we run them on, if needs be afterwards, if they're not responding, you run them on variable rate infusions. For hypoglycemia, obviously, if it is to 4 to 6 millimole per liter B, you give them 50 mils of glucose, 20%. If it is less than 4, by the way, the trend here is just to give them 100 mils of this rather than 50 mils. Okay, and above all, whether it is elective, emergency, the patient blood sugar should be checked hourly while they are in theater. Fine. Turning to the patients finished theater, going back to the wards, I think we touched on this before, but I'm just going to mention it very quickly. In this case, depends very much on what they are on. As we said, if they take long-acting, they continue on 80%, and they continue with the 80% post-operatively until they are fully feeding, and then they can go to a normal diet, actually. And then for the biphasic, intermediate, and short-acting, they stop all that until they start eating. Again, most of the oral hypoglycemic, they basically stop them until they start eating. And that's the post-operative, how they return back to the normal medications. Timing is very important. If the patient is on a variable rate infusion, they should continue on their variable rate infusion up to, the variable rate infusion should continue for half an hour to an hour after the start of subcutaneous insulin. So they basically eat, they have the subcutaneous insulin, but they keep the variable rate infusion carrying on for another hour. For oral hypoglycemic, you just start it at the same time, basically. In the next 5-10 minutes, we'll talk about what should we do in special circumstances, really. Anesthetic technique. I think there's pros and cons for everything, but basically regional anesthesia should be encouraged. It reduces the risk of nausea and vomiting, and obviously has an opioid-sparing effect if you use it with a general anesthetic. Of course, the patient is more prone to epidural abscesses, having had diabetes and also hemodynamic instability, increased risk of neuropathy. So what I'm trying to say, I guess, is it's a risk-benefit ratio. So you have to put this in balance when you run. But personally, if the patient having got neuropathy and diabetic, I usually very much try to do a regional block, whether or not it is with a general anesthetic, that's something else. Enhanced recovery, it's very advantageous in these patients. Enhanced recovery of patients undergoing surgery, of course, advantage are minimal preoperative physiological trespass, early post-operative nutrition, early mobilization, reduced length of stay. All this is our targets for diabetic patients anyway. But on top of all that, you reduce the risk of iatrogenic harm by insulin, which is a factor on why they actually deteriorate. And I know it's going through your minds now about the glycemic control and the figure of sort of 69 and the figure of 4 to 10, or 6 to 10, I should say. This is the current recommendations. The HbA1c has to be 69 or 8.5% or less. The capillary blood sugar, I think the figure is wrong. It should be between sort of 6 and 10. But we have to be reasonable here. We will come some patients that, and this has come from recommendations, not from me actually. And the recommendations I'm laying in front of you today are a combination of Association of Anaesthetists of Great Britain and Ireland and the NICE guidelines, the National Institute of Clinical Excellence. And they recommend, and there's certain patients, you cannot really bring it down to 69. And patients on steroids, for example, for any reason, their blood sugar will be a little bit higher. people stressed out sometimes, and they're consistently having a high blood sugar. And in this case, and the benefit of the operation outweighs the risk, you can accept HbA1c up to 75 and a capillary blood sugar up to 12. Okay, and that will be acceptable. The other controversial thing, but actually not very much controversial, is intraoperative fluid management. Okay, basically it depends. If the patient is on variable rate infusion, they take the fluids on the top, which is the glucose 5% and saline 0.45. Okay, and they run usually about 83 mils an hour. That's maintenance fluid. If they are not, you can use Hartmann's. Very important here, and if you go through the evidence and the recommendations by the bodies, they talk about the overall aim in general is to keep the blood sugar between 4 and 10. You give enough substrate to avoid any sort of metabolic derangements like ketogenesis, for example. You have to give enough sodium and potassium, because let's face it, if you give them dextrose 5% and 1.5% saline, they will develop hyponatremia, and if they're having insulin, they will develop hypokalemia. So you have to be reasonable here in the way of thinking, and they appreciate in the recommendations that most of the institutions don't have the above fluid, so you may give them Hartmann so long the liver is fine, and that's acceptable practice. Other quick consideration the next minute or so is some sort of operations that they use carbohydrate loading for it. Usually not very recommended, but there is recent evidence that you can give it to them. You just have to keep an eye on the blood sugar, and there is no difference between patients who have carbohydrate loading and those who didn't have carbohydrate loading. You have to be very cautious giving non-steroidals for patients with on metformin or glitazones. Dexamethasone is an issue, but could be given cautiously. Okay, but you have to monitor the blood sugar every 4 hours if the patient really need it. Metformin very cautiously in patients with acute kidney injury and radiopaque contrast will be used during the procedures. So this has to be very carefully handled, really. So this is what we talked about, and I'm sorry, just going through quickly. I mean, this is a subject that we can spend a day talking about it, but we very briefly address the stages of perioperative management, the aim of each stage, and some controversial issues that will basically and your training thoughts. Thank you very much. Thank you.